Yeah, hello, this is Marc Suhrcke. I'm a health economist and I'm based in LISER, where I coordinate the research program on health and health systems. I'm also a professor at the Center for Health Economics at the University of York. I will be talking about a health economic topic, maybe the first in this series. And the title of my presentation is More Cost-Effective but Less Equitable, which is essentially about the idea to incorporate equity considerations into economic evaluation of health policy evaluations. An issue that is quite new in the research field. I acknowledge some of my colleagues in New York in particular who have pushed the frontier in this domain quite a bit. So I will be talking about four sections here. First, I kick off with some basic recap of what economic evaluation is generally about and why do we need to make choices based on economic criteria, or why would we be better off if we did. Um, Before I move on to the key aspect here, which is the idea to incorporate equity into cost-effectiveness analysis. I explain a bit the basic principles, and then go on to illustrate those in a case study from the UK in the area of public health, given the seminar series here. And it's about bowel cancer screening in the UK. And I'll wrap up with a few concluding remarks and some open questions, perhaps. So why do we need to make choices based on economic criteria? Now, the fact of the matter is that even in rich countries, even in countries as wealthy as this country, at the end of the day, resources are limited in any healthcare system, in any public system in the world. There are limitations. We cannot never fund as much as we ideally would want to fund. So we have to really make choices about how we allocate our scarce healthcare resources. Economic evaluation then comes in as a way, an approach to inform resource allocation. Really, our main principle here is that we want to fund or recommend funding those interventions which do the most good in terms of achieving the most health gain out of a existing budget. The key concept, key notion in this is the notion of opportunity cost. If we spend our money on one thing, we cannot spend it on something else. So opportunity costs are the value of the next best alternative. And it is such that, if resources can be better spent elsewhere, then an intervention is not considered as cost effectiveness. Hence, we would not recommend it to be funded. Now, the traditional, some of you may be familiar with the traditional picture or the traditional cost effectiveness plane. Suppose we compare two interventions to each other, one that already is in place to a new innovation, say, precision public health, some fancy intervention, and promising. So we can compare the two then in terms of their differential effectiveness on the x-axis here and differential costs on the y-axis there. Depending on where that new intervention is located, then we recommend a decision to reject or accept it for funding, or for recommendation for funding rather. Now, in some of the quadrants here, the decision is easy. Now, so say it is located in the northwestern quadrant, where we have where the new intervention would be both more costly and less effective. The decision is clear. We're not going to take that. We reject that. On the opposite side, now, if we have the new intervention showing greater effectiveness at less costs, then it's a no-brainer. Now, then we obviously accept that. In most cases, probably, we will have a situation where the new fancy intervention, might promise greater effectiveness, but at a higher cost. So then we need to weigh how worthwhile is that higher effectiveness given our limited budgets. And that's where the opportunity cost comes in now, because we could be spending the money on the existing system, which gives us a certain return on that investment in terms of health. And yeah, so this is reflected in the opportunity cost in that line that crosses here the quadrant. If our intervention is below that, then we would accept it because it has a high enough effectiveness, additional effectiveness for the higher costs. If it's on the left-hand side of that, we would consider it as cost ineffective. Same goes for the southwestern quadrant there, where we may have a case there where we have a less effective and a less but a less costly intervention. So again, there's a decision to be made here. Now, a big criticism of traditional cost effectiveness analysis, as I've just very briefly described it, is that it only looks at average health outcomes. Yeah, it doesn't care about who benefits in terms of the health gains. Is it the poor? Is it the rich? Someone in between. So, and given that health equity, distribution of health across different socioeconomic groups is an important or increasingly important policy objective or policy concern, that's of course a limitation there in cost effectiveness analysis. Hence, the idea to incorporate explicitly equity concerns into cost effectiveness analysis. This is important because clearly now we could have two interesting challenging decision problems. Now we might have an intervention such as this one, which is basically extracts the northeastern quadrant from the previous cost effectiveness plane. We have an intervention here, Y, which is cost effective on its own, but we also know from our research that it increases health inequalities. So what do we do there? What do we weigh more heavily? Are we prioritizing the fact that it's cost effective, or that it increases inequalities and hence should be rather not funded? Or we have a situation which is the reverse. We may have an intervention X, which is cost ineffective, but on the positive side, it may reduce inequality. But by how much? And does the reduction in inequality compensate for the lower or the cost ineffectiveness? We don't know. We need some tool, some guidance there to make decisions, or these informed decisions there. This is what essentially this idea is about, to incorporate equity into cost effectiveness analysis there. This is really, I've already basically said what is on this slide. Now, again, traditional CEA is just about efficiency in the sense, just about average health and average cost effects. Whereas distributional cost effectiveness analysis, DCEA, adds information about equity into the distribution of costs and effects. So I'm not going to talk much about this issue here, but of course we need to at some point also have a discussion about what do we mean by equity there. Now this is different people mean different things when they talk about equity here. It's clearly different from inequality. Now to economists, inequality is just a variation or differences in the outcome, say in health. There's no value judgment attached to that. But equity, assigns some normative judgment of fairness or social justice to a certain allocation. So which means then we need to be explicit and define what we mean by fair. and that requires social value judgments. So for simplicity here, we think of equity as socioeconomic, or inequality as socioeconomic inequalities in health, variations in health by socioeconomic indicators. But you could legitimately raise the question whether all socioeconomic differences in health are really unfair. And then there are other outcomes, other notions of equity which could be brought to bear here, but we're not touching on that. For instance, the important and useful concept of equality of opportunity, equality of outcomes. That's for the discussion potentially. Now, if we then incorporate equity into the cost effectiveness analysis, we could draw a similar plane as we did before, and the cost effectiveness plane. Now we call it the equity efficiency impact plane, where we compare, again, two interventions, one existing one and a new one, on those two dimensions, on equity impact on the x-axis, which one increases equity more, and efficiency impact on the y-axis. So what is the net health benefit? So net, which is subtracting then the opportunity cost from it. Now, ideally, we would want to be in a situation where we have a new intervention which is both more cost-effective and improves equity. That is not often the case, I would think. Neither do we want to, but that would be, of course, the best of both worlds then. No? But then we have the opposite there, the lose situation here, where we have cost-ineffective interventions that harm equity. Most often, we will have probably cases where we're in between. Now, we either have a cost-effective intervention that harms equity in the northwest quadrant, so a win-lose situation, or we have a lose-win situation where we have cost-effective, ineffective interventions that improve equity. So we have to acknowledge that these trade-offs are real, although when we need to deal with them. Now, this is one picture which illustrates this, not looking at high-income countries, only looking at low middle-income countries, and just looking at outcomes, health outcomes, in particular under-5 mortality here, where we compare a measure of average health, which is under-5 mortality, across countries to a measure of inequality, health concentration index. And then if we drew a line here, a regression line, you would see an inverse relationship reflecting that trade-off. So you can either have low average under-5 mortality and high inequality, such as in Brazil, or you have the opposite. You have a high average under-5 mortality, but a low differences, low inequalities. A more interesting part to us perhaps here is a study that colleagues of mine in New York have also done, but they looked at NICE. So this is the National Institute of Clinical Excellence, Clinical and Public Health Excellence, which makes recommendations on interventions. Now it's guidance on public health, for instance. So they looked at a large number of studies that were recommended in the NICE public health guidance and tried to very somewhat crudely, but still, calculate the equity efficiency relationship of these interventions. And so this is essentially using the same quadrant as the simplified one that I showed earlier, where we have a measure of equity on the x-axis, a reduction in SII, that's the slope index of inequality. I need to discuss the details here. Take it as a measure of equity impact, and we have the population net health benefit on the y-axis. Surprisingly, here we see that most of the interventions recommended are in the win-win area, really. Yeah, so they're improving equity, and they're cost-effective, which is interesting, perhaps surprising. We have a number of interventions than in the area here in the northwestern area, where we have a higher cost effectiveness, but a harmful effect on equity. Now, we could imagine that this is often the case with behavioral interventions or mass education campaigns, which are taken up more easily by more higher socioeconomic groups. But then we also have a number of interventions that are indeed uh, less cost ineffective, and they harm inequality. So hence we would not recommend funding those. So this is an interesting way of illustrating that. Now we come to this specific case, and I need to speed up a little bit, of bowel cancer screening program. Now this is the second most, bowel cancer is the second most common cause of cancer deaths in the UK. Now, this is quite old figures here, but it's still the case today. There's a free national screening program that was rolled out in 2006 to all 6 to 70-year-olds in England. And it has been shown that those who attend screening have a 25% reduction in their risk of dying from bowel cancer. The problem being, though, that less than 60% of those that are eligible for screening participate in the screening. So any of these DCEAs starts from a current distribution of health. So this is just illustrating the general distribution of health measured in terms of quality adjusted life expectancy, male, female, and then by different socioeconomic groups. Now, this is the index of multiple deprivation, an area-based index, and we see the expected rate, and no need to just discuss about this in detail. There is socioeconomic inequality in screening uptake as well. If you look at the right-hand graph here, we see that the least deprived have obviously the highest uptake of screening, as you would expect with probably all screening programs. Now, there are two options that have been considered in this study and in policy discussion to redesign the program. Option A is a targeted approach where a reminder would be sent by the doctor to only the most deprived areas, so which would be expected to increase the uptake in those areas by 12%. And an option B, which is the more universal approach, where we have a standard reminder which everybody gets that is eligible, which increases uptake overall by 6%. And what we find then, or what the study find really, is that you have very a differential picture, and it's important to take into account the distribution of the effects by socioeconomic groups. Now, if we go with the universal approach, overall it improves health the most. Now, if you look at the left-hand figure here, the dark shaded area, we have a higher incremental quality gains, both for males and for females, compared to the targeted one, which is the unshaded area here. But then if we break that up by socioeconomic groups, we see a reversal there. Now we obviously see, the targeted approach being more effective in the lower socioeconomic groups, but not in the higher ones. Of course, they can't because they weren't targeted there. So if reducing inequality was the sole policy target, then the targeted approach would be chosen. But of course, it's about both. Now we need to really, and this is what distribution and cost effectiveness analysis does, we need to really be explicit about how we value the inequality versus the average changes. So we need to define a social welfare function, which really makes this explicit, the trade-off explicit, and in particular a key parameter there is this inequality aversion parameter there. No need to go into the technical details here, But what this does, it essentially describes the trade-off between total health and the level of health inequality. Um, and there are several functions, several potential functions. This a study that I'm presenting here uses two. No need to go into the details there. The Atkinson social welfare function is a very popular one. If we do that explicitly, yeah, so really then the outcome depends on the size of the inequality aversion. Now, what is the size of the inequality aversion? We don't know unless we examine that. So, of course, you can of course imagine that there's less inequality aversion in, say, the US compared to countries in Scandinavia. But what level of inequality aversion is there in the UK, or in Luxembourg? We don't know. We would need to examine that. In the UK, some studies have found an inequality aversion parameter of about 10, yeah, which is this vertical line here. And what this figure shows is that it's a way to then really assess, now, given different levels of inequality aversion, which of the two approaches, universal versus target, is the preferred approach once you incorporate both overall health benefits, net benefits, and equity. And we see that, of course, yeah, the lower the inequality, the lower the inequality aversion, so the less we hate inequalities, the more preferred universal approaches are. But then once we exceed a certain level, of inequality aversion. So once we don't begin to not like inequality as much, the targeted approach becomes the preferred one. So this is, yeah, just a very quick illustration there. And I need to really quickly wrap up with the last remarks here. What I've tried to get across in this brief talk is that, of course, yeah, economic evaluation of both the costs and the benefits of policy interventions is key to informing priority setting, but it has traditionally ignored equity concerns, and I think increasingly equity is important. Recent work has filled this gap, and this is particularly useful in the likely many cases where we face a trade-off between achieving higher net health gains and improving equity. And if policymakers are serious about what they say, which is health equity is important, then their resource allocation system should at least be informed, guided by this kind of evidence and approaches. An open question for discussion is maybe, now how would now precision medicine or precision public health fare under such an economic evaluation that would take into account both the average health benefits and the distribution and the costs? We may want to discuss that. I finish here. Thanks very much.